Okay, well, hello everyone. So I'm here to introduce Dr. Cusimano. Dr. Cusimano is a cardiac surgeon at the Peter Monk Cardiac Center, and he's a professor at the Department of Surgery at U of T. He earned his medical degree from the University of Calgary, then interned at the Atlantic Canadian provinces before completing his residency in general surgery and then cardiac surgery at the University of Toronto. He became a staff surgeon at the Toronto General Hospital in 1993, the first Canadian of Italian heritage to achieve this status. In 2006, Dr. Cusimano became the first non-Chinese physician to teach cardiac surgery at Xinjiang Medical University in China and was awarded an honorary degree for his work. He has since made return to visits to China to continue teaching cardiac surgery techniques used at the Peter Monk Cardiac Center. In 2016, Dr. Cusimano led the Toronto Cardiac Tumor Conference, which was created to share knowledge and best practices about the diagnosis, treatment, and management of benign or malignant tumors of the heart. So everyone, please give a hand in welcoming Dr. Cusimano here, and you are good to go whenever you're ready.
All right. Well, thank you very much for allowing me to speak here. It's a topic that's very important in my mind. I've been all over the world to speak, including South Africa. I have fond memories of the UofT. I don't hope I pronounced that correctly, but I've had a long interest right from when I was a medical student for global surgery. And I was asked to speak about, I thought, the consequences of COVID-19 on international education, but whether you wanted me to speak about that or not, that's what we're going to speak about. As just a disclosure, as you mentioned, I run a cardiac tumor conference every year in Toronto, and I've invited the experts around the world. It's going ahead by itself. I've invited experts around the world to speak on different topics. And from this, I've learned a lot. If you wanted to learn about cardiac tumors, anything about cardiac tumors, go there. There are past presentations. You can learn all about topics, and they're free. It's free to join, free to attend the meeting, and it's every year in January. Who am I? As you said, I'm a cardiac surgeon at the Peter Monk Cardiac Center at Toronto General Hospital. I have a surgeon educator role. There are different roles in our university. I'm a surgeon educator. I'm a professor of surgery. I hold a Cinnamon Professorship in Cardiovascular Innovation and Education. And I've been involved with university education and the Canadian national education, as well as international education, since, as you said, 2016. I was a part of the revamping of the cardiac surgical program in Canada. As people in Canada know, there's been a big change in the way resident education occurs, and I was part of that at the national level. Tried to bring some of that internationally as well. I educate about cardiac surgery and residency training around the world. I teach mostly at the resident level and above. I do some medical student education, mostly in small group sessions. I've been involved with the development of clinical skills labs around the world, developed and program curriculum at the local, regional, and national level, as I mentioned, and program evaluation and enhancement, specifically of cardiac tumors. Cardiac tumor specialty doesn't exist, and I'm trying to get it to exist. I think once I get a specialty of cardiac tumors, I may retire, but hopefully it's not too far away, but I suspect it's going to be. These are the areas around the world I have taught in. I have taught as global surgery in the United States as well. Some people find that hard to believe, but it's true. First world nation can teach in a first world nation. There's lots of things that you can do to help, and education isn't what you may think of. There's many aspects. Other areas of the world I've been invited to speak about, but haven't actually been into the operating rooms. Those are the yellow areas. Most of my global education has been in China. I think I've taken about 11 trips to China. Most of it has been in Xinjiang, which is the biggest happy face there. But I have traveled around the country teaching in the hospital, and I've visited a lot of the country as well. So it's been around the world, but mostly in China. The objective of my talk are really to identify the benefits and the challenges of international education in non-COVID times, and to identify the challenges that COVID brings to education. As you mentioned, I started teaching in China in 2006, and this is the day I got off the airplane. This is Tiananmen Square. For all of you young people who don't know what Tiananmen Square, it's has a very bad reputation in terms of the student protests and how many students were killed on this very site. But it's a central square in Beijing, and on one side that's the national government there, and the other side is Mao's tomb, and the other side is the Forbidden City. So it's a central square of Beijing. It's the heart of Beijing. It's a beautiful place to visit, very, very historic. That was the day we landed. Those were the Chinese flags, as you can see. When we left, we had a new invention that was a cell phone. This is a BlackBerry cell phone, the first generation. He was so proud that he had this new cell phone that we could use. Over here is Peter Liu. He was an anesthesiologist in our hospital, and he came from Xinjiang, and he knew of my interest in education and asked me if I wouldn't mind going there to lecture and teach at the 110th anniversary of the founding of their school. And I really was the first Canadian to go there, and there were a lot of cameras around. But we brought Barry Rubin, who was a vascular surgeon. He never actually got to do any operations, which was quite interesting. It was a shock to us because the families of the individuals didn't want to have surgery done, but in cardiac, they were a little bit more open to that. Vascular surgery was a new sort of thing back then, and they were reluctant to have their families undergo surgery. When we arrived to Beijing, we saw a lot of bicycles. There were a lot of bicycles everywhere. This has changed over the years. Now you see very few bicycles there. They're now all electric. One of the other things that I thought was a very foggy day in Beijing the day we arrived. And I was told later on that this is a natural, normal day in Beijing. Now that's Mao Zedong's tomb in the background. You can visit it on Tuesdays and Thursdays if you bring your passport. But that's something I had never even seen before, that much pollution. And it was something different. We had some students visit us from residents, not students. Actually, they were staff surgeons visiting us from Beijing for 6 months after I went there. We set up a reciprocal kind of a program. And the one thing they always commented on were the skies in Canada, how blue they were. And you can see the skies they were dealing with in Beijing, and you can understand why. Masks were very common even back in 2006. I didn't know why they used them, but there were a lot of people that used to have masks, and this was back in 2006. So something that's very commonplace now was common back then in China. Perhaps for the pollution, perhaps for infections purposes. I don't know what they were, perhaps even keep themselves warm, but we saw a lot of masked people. It's only after I came back from Beijing and China and looked at my pictures, I took a lot of pictures, that I realized that the pollution really was everywhere. And this was inside a building. This was William McClure, who had actually founded this hospital. So I actually wasn't the first Canadian. It was the second Canadian. The first Canadian founded the thing 110 years before I'd gotten there. But there really was a lot of pollution. This was something very foreign to me. It's something I didn't really realize very much until I had left and people told me that there was pollution. I didn't know what it was. I thought they just had a lot of foggy days. In those days, we did a lot of travel around in a train, by train. It was a bit dusty, but the trains were a way to get around. We used to go in sleeper cars to go to different cities. Ever since, from the time I started to the time I last visited there a couple of years ago, 3 or 4 years ago, we went from this sort of train to the bullet train. It was traveled 320 kilometers an hour. It turned an overnight train ride from Beijing to Xinjiang to a 4-hour ride. So a big difference from the time I started to the time I ended. This is what we looked like when I got off the train that first day in Xinjiang. There was believe it or not, you can see there's a truck that picked us up. It was a really, really, really foreign land to me. And that's one of the things that you may realize when you go travel to different parts of the world. Things are going to be very, very, very different than what you're used to. Embrace that. Have it as something, as an educational thing, not as something to scare you. I was actually very excited when I saw this. That's why I took the photograph, because it was something so foreign to me, something I'd never seen. And it was an opportunity for me to go into something I'd never seen and learn from it. So it's great. It was great. Education, is always two-way. It's never, I'm the expert, I go there and teach them. They teach me as much as I teach them, whether it's verbalized or not. You always learn something as long as your mind is open to learning. When you go someplace new, there's a lot of interest in you coming there as a foreign person. And I suspect it'll be the same when you're a medical student, not obviously as much as if you're going there as an expert. There's always interest in what you're doing. You'll see things that are different than you're not used to, heavy blankets, socks, because it doesn't show it here, but it's quite cold in the hospital. People will be filming you because it's something new. This is more if you're a an expert like I was when I went. But there's a lot of interest when you go. When you go as a foreigner, people will come out of the woodwork to see you. In this particular case, they heard I was coming, and droves and droves of people were there. I would stay there till 10 or 11 o'clock, seeing different people with different problems. They'd come with their films. They'd want your expert advice. Sometimes, however, you're going to see people that have problems that you've never dealt with, or completely out of your control, and not out of your control, out of your area of expertise. And you're going to see that. And what do you do in those times? You see somebody who has a problem that you know it's a problem, you know it's a big problem. This little child, beautiful little boy, was brought by his mother, hoping that he'd get some help from me. And I had no idea to help him. So what do you do in those times? Well, what you do is you be a doctor. And a doctor is a person who gives a smile, shows a person the time of day, gives them a pat in the back or a little nip of the chin or something like that. Believe it or not, you'll help that person. You know, that little child there went away pretty happy. He saw somebody. The parent was happy, even though I couldn't help him with the problem that he had. But you are going to see this. You are going to see people you can't help. And that's not only in foreign lands, it's also in our own land. You have a person who's got end-stage cancer, or is dying, or has some problem like homelessness that you can't really deal with. But you can always do one thing, and that's to give them the time of day and give them some moral support and some emotional support. That's really, really important for you to do. You're going to see things that you're not used to and you may not understand. This is a fairly modern hospital that had no electricity during the day. But you'll see other things that you never really realized. And something that made me realize that it's true all over the world is people care about their families. People come to the hospitals, they care about their families, and these people would be there at all hours of the day and night in the stairwells, et cetera, to be close to their families. And it just brings home the fact that health is the same everywhere you go in the world. So these are the things that you may not see as much in Canada, but you'll see more in other countries. And again, it's something that teaches you that, yes, things are the same everywhere in the world, and these people really do care, and you really should give them the time of day, whether they're visible like here or invisible like they are in our countries, especially now during COVID, when the patients' families are not allowed in the hospital. It's really important to pay attention to them as well as the patient, because, you know, care or health affects not just the patient, but the family as well. It's a overwhelming similarity around the world. Even out of the hospital, you may find things that you didn't recognize or didn't realize, but it doesn't take much time to adapt to the areas that you're going to visit. This is the washroom in Beijing or in China. I'd never seen these things before, but it didn't take me long to realize I have to bring my own toilet paper. They may not have as many materials as you do. This is the anesthetic machine in Xinjiang when I first got there. They had a monitor and a defibrillator and probably a rudimentary, I don't know, because I'm not an anesthesiologist, rudimentary ventilator, but they make do with what they have, and they do really a good job with it. But they do have local realities. Here they use string to tie cannulas together, something I had never seen, but it makes sense. They have sutures that they load into needles, something I had never ever seen in my life. The instruments aren't exactly the same instruments as we have, but they make do, and it doesn't take long for you to get used to the local realities. These were the sutures of the whole hospital. This was a regional hospital. This is one of the highest level hospitals in the region, and those are all the sutures in the hospital. These nurses showed me they were so proud of their storage space, and even though it may seem meager to us, to them it's a sign of pride. Here's our anesthesiologist. That was all the drugs the anesthesiologist had available to them. I think they must have had about, I'm trying to remember the ORs, maybe 15 ORs. These were all the drugs that they had. So this fellow here was their anesthesiologist. He was an outstanding anesthesiologist. He could give anesthetic anywhere. And in fact, if you think about it, if you're giving anesthetic with a limited amount of drugs for the whole hospital, you can imagine the quality of his anesthetic must be amazing, and I'm sure it is. You're going to see things again. There's many ways to skin a cat. Here they are with the patient underneath there, draping the patient in Canada. I don't know how it is in South Africa, but in other parts of the world, but in Canada, the people that drape the patient are all prepped and draped. Here, this fellow here had washed his hands and he's giving a helping hand to drape the patient. It's different. And I asked, how is it that they can do this sort of stuff? Allow people that aren't gloved. And they said, well, they've scrubbed, so their hands must be sterile. So it's perfectly fine. Again, and education from that direction to our direction, I don't know if it will go well here, but it is an education. There's very little wastage of materials there. Everything was used because they may not have had as much as we're used to here, but they used everything and everything worked perfectly fine. Here's an example of the chief surgeon there lifting off some of the gowns on the table to look for a pair of gloves for himself. When you go places, that was me buried in there. There's a lot of interest in terms of what you're doing. A lot of people come that may not even be part of the cardiac surgical services and come and watch you. I'm way over there, lots and lots of people watching. It may not be the most sterile, but it works. I asked them about their sterility and I asked them about their wound infection rate. It was very, very low. So again, in many ways, to skin a cat, this would not fly in Toronto, but it was perfectly fine. China is a foreign language place to me, as it may be to many people, and it doesn't have to be China. I've been to other places that aren't English speaking primarily, but you've learned pretty quickly to make your needs known. Here in China, they used to have one person, and this lady here spoke some English, so she was able to understand some English. But using your hands, using your fingers, you could do something complex like cardiac surgery. In this picture, you can see how we tied the cannulas together. I don't know if you can see it from your spot. So things worked out, things I'd never done before, but everything worked out. And even without Chinese being my primary language, or even the secondary or third language, we were able to make things work. Sometimes a little bit more slowly, but in essence, we were able to make things work. As a foreigner, you will stand out. Sometimes not so bad to stand out, but you will stand out and embrace all of that. Every place I go around the world, I always give a lecture. Here, Dr. Rubin, I think they were watching me operate, but we always give a lecture. And I always insist when I go overseas that I give a lecture of some sort. And sometimes I talk about the topic. Sometimes I talk about cardiac tumors because I'm interested in that. But many times I talk about international education. And some of the countries don't have as organized education as we do in Canada. And having had experience in education at the university and the national level here, I try to let them know what education is like in Canada, and perhaps and bend them a little bit towards that sort of education. I know there's many different ways, as I said, to skin a cat. I've gotten student competitions, suturing competitions. I've gotten clinical skills labs made and things like that, but I always give a lecture. That's my fee for attending their place, is to give a lecture. That's my only fee for attending. Sometimes they will videotape you because they, for some reason, don't want a lot of people around. In this particular case, they were videotaping me and it was broadcast. I thought again to the auditorium. In this particular case, I asked if anybody had any questions from the auditorium, because they had videotaped me the day before for the auditorium where people were watching. I showed you that picture. But in this particular case, they said there's nobody in the auditorium. And what they had done is they had interrupted live television for all the radio stations in the province of that Chinese province I was in to broadcast my operation live. I don't know why, but they did that. So the population is about 100 million people. So anybody turning on the TV set during that operation was watching us operate. It was a little bit nerve-wracking, but it was education nonetheless. Some of the places you go to is very primitive compared to what you're expecting. You know, we went with that modern first generation BlackBerry, and here we'd seen an abacus. I'd never seen an abacus, and they showed me how it works and things like that. So that place was very primitive. That particular area that I'd gone to, primitive in terms of things that I had not seen that I would expected them to have more advanced things. But other places are highly, highly, highly advanced. Some places are much more advanced than the places we come from, that I come from. This is a place that I had visited, and we had not had this angiogram machine in our hospital yet. And yet they had this technology in their hospital. And I was asked to go to this place to educate. And believe it or not, you can educate, because if they're asking you to come there to do something, there must be something that you're there to teach. So sometimes I feel that I have nothing to teach, but by the end of it, sometimes what they want is validation, or see what they're doing, if they're going in the right track, whether this newer technology is advantageous to them, what do I think of it, et cetera, et cetera. Sometimes knowledge from your side or where they're coming from will help them as well. So sometimes you come from a primitive place, sometimes you come from a more advanced place. As I said, I've gone to the United States and they're equal to us. I don't think they're advanced to us, but they're equal to us. And you can educate there as well. I've seen lots of places, lots of things I'd never even dreamed of or had seen in National Geographic or on television or in documentaries before. This was obviously in China. This was in Ethiopia. This is Lucy. It's the used to be the oldest hominoid ever found in the world. That's in Addis Ababa. So I'd heard about that in documentaries and read about it in books and history and stuff like that, but I was actually able to visit Lucy herself. When you do go, make sure you do take time out to visit the country. It's a shame to visit some faraway place and arrive on a Thursday and leave 4 weeks later on a Thursday and not having gone out to see the country, because there are so many things you've heard about and seen, and even if you hadn't seen or hadn't heard about it, you learn so much by visiting the country, not just places that you may have heard about, but also to visit the people. The people, I think, are amazing. People ask me why I went back to China so often and why I stuck to a small town instead of Beijing. I have been to Beijing to teach there and Shanghai and things like that, but it's because you see China, you see the people, the country is not the country is the people. And make sure when you go there, you take time out, whether it's to travel within their country or to spend the time with the people, even if you need an interpreter, to see what the people are like, because that's the country. The country or the people is not the places, although there are some places to visit to see. February 2020 was my last educational trip, so I haven't been anywhere in almost 2 years. I went to Ethiopia. My plan in Ethiopia was to open up cardiac surgery, have a cardiac surgery program for the country. They didn't really have a public cardiac surgery program. The way cardiac surgery worked in Ethiopia, and I suspect still works in Ethiopia, is they have missions that go to Ethiopia where they bring the whole team there and they do cardiac surgery for some individuals and they leave. But I wanted to go there, and my goal was to go there and open up a program in cardiac surgery so that they would be a public program. We wouldn't have to rely on people coming from other parts of the world to help them. The hospital I went to was called Lions Hospital. Here's what Ethiopia looked like. This is Addis Ababa. It's not all like that, but the Addis Ababa is a place that has very modern buildings. The United Nations has a compound there, like a very big African headquarters there. So it's very, very modern, all the way to places like this. So you'll see many different levels of people's lives there. But when I went to the hospital, it was the most modern hospital, biggest hospital in Ethiopia. And they had an echo machine, and it was quite nice. I was really quite happy. So that was our goal. I found out that this hospital, they had a defibrillator machine and a fair number of drugs for emergencies. And I found out that hospital had, for cardiac surgery, 10,000 people waiting for cardiac surgery. So you talk about a backlog from COVID. They had 10,000 people waiting. They had 2,000 people waiting on their waiting list with cardiac myxomas. I'd never seen such gigantic myxomas. And my goal there was to choose 4 or 5 patients that we would start on, the 4 or 5 easiest patients that we would start on for coronary surgery to get their program going. And as you might imagine, a lot of those people were already dead. So they had a lot of program, a lot of need to start a cardiac surgical program in Ethiopia. Their operating rooms at first looked really quite nice. And they had quite a modern operating room with a lot of natural light, which is always nice to see in an operating room. We don't have natural light, but I love an operating room that has natural light. They had even an echo probe, and we traveled with an anesthesiologist. I like to travel with somebody else. Here, I brought an anesthesiologist. I like to travel with a student, be it a resident or a medical student. I haven't had a medical student yet come with me, although I've had some medical students have been interested in global surgery. I've mostly brought residents with me, but I like to travel with the staff. Here's a staff. He was teaching anesthesia, teaching echo, and at least seeing how they were with respect to their anesthetic techniques. This young doctor here, she was an outstanding anesthesiologist, just like the anesthesiologist in China. She was amazing. She was really good. I did meet a medical student there. He was from the United States. He was a medical student. He's now a cardiac surgical resident. Very nice guy who was there as a medical student to see what it was like in Ethiopia. So we remained friends. It's quite nice to have met him there. Very nice boy, nice guy. But you know, even though it looked like very modern, here was their operating list. Now, I haven't brightened these up. The lighting wasn't very good, but when you look at it, their operating room in OR1 or table 1 was if there's an ICU bed with mechanical ventilation available, if the ICU bed is not available. One day, so there's the reality. You're in the biggest hospital, biggest public hospital in the country, and there's a reality if they actually have mechanical ventilation available. So really this sort of thing is a real thing, even though they're much more advanced than the other places around their country. Even though you're going to the top level, there are realities that you may not have understood until you've gotten there. I always like to look at the operating tray when I get to a new hospital to see what they have in their tray, to see what kind of materials they have. And this looks, for those non-cardiac, looks really good. They have cables for pacemaker. Believe it or not, I've been to hospitals where they do cardiac surgery that they cannot do a pacemaker after the operation. It creates quite a problem if the heart doesn't start after the operation. They need a pacemaker, something very, very basic. I've asked our guys at our hospital when we have a pacemaker that we stopped using because we had a new model to give them to me. And when I start traveling again, I'm going to bring a pacemaker and give them a gift of a pacemaker. So I always look at the tray. Now here's this particular tray. I'm just giving an example here. This is a sternal opening tray. So all cardiac surgery needs a sternotomy, most of it does. And it looked like it was really quite nicely modern. That retractor looked quite modern compared to what I've seen in the past. But when I go through this, as medical students, it looks nice and modern too, nice and shiny. I had used this in the lab. This is called a Lipsky knife. I had used this in the lab to open up the sternum of animals in 1987. I've never seen it in a human. We use a sternal saw. We don't use that knife. What they do with that thing is you hook that thing underneath and you take a hammer and you hit to this part here and it uses a blade and it goes through the sternum. We use a sternal saw. What they use is this to cut through the sternum. They use a scissors. And I said, really? You use a scissors to cut through somebody's sternum, sternal bone? You can use a scissors? And sure enough, there he is cutting through somebody's sternum with the regular scissors. So nice modern instruments. They didn't have a sternal saw, it broke, and they're making do with whatever local realities they have. And that's what you have to do when you travel. Whenever you have to travel, it may look very modern, but the realities are really quite different. These people had modern cell phones. I showed you the cell phone of Barry Rubin when we first went to China. It was a modern cell phone for the time, but it wasn't very modern. Here they have a modern cell phone. It's got lights. But what had happened in this particular case, in this time, that's why I took the photograph, is the lights of the hospital went out. They had a shortage of electricity for the hospital, and they used their light to illuminate the patient because all the monitors went off as well. There was no emergency lighting. It was just lighting based on people's cell phones. So it was a real eye-opener for me. It shouldn't have been, but it's a real eye-opener for me that the local realities may be different than what you're used to. It makes education different than what you're used to. It makes education very difficult to talk about sometimes. Well, I was there in February and they're starting to get their COVID ward. This was the COVID ward at Addis Ababa in the Lions Hospital. There were two wards. This was the public ward and this was the private ward. And they had no cases. They had very few cases around the world, but we could tell that the world was going to shut down very quickly. And shortly after I got back, they did shut down. They shut down playgrounds, as people in Canada know. I don't know if they did that in South Africa, but they shut everything down. We had ORs available for COVID patients that we might have to operate on. We had them shut down. We had different protocols brought in for COVID, et cetera. But the whole world shut down, as did we. So we've had now 3 waves. The 4th wave has started as well. This was taken a couple of weeks ago, but there has been a 4th wave. It's hard to say whether there's really 3 waves. Did we call this a wave and this a wave and this a wave and this a wave and this wave and another wave? If you look back in 1918, there were 4 waves that came. So it's pretty similar to what happened in 1918 flu epidemic. But how has education changed? Well, there were no clinical visits at all by the students or the educators. Unlike South Africa, as we've heard, the students were kept out of classroom from the March 16th was their last in-house class to August 2021. We had no students. For a number of months, they let them back sooner, but we had no residents as well. And it was really devastating for the residents, especially in their senior years, where they were able to fine tune and polish off their education. Their education completely stopped. And I don't know why it happened. But it did. The younger people who are less prone to COVID than the older folks were taken out of the classroom, which was the hospital. We all use PPE, so everybody was protected by PPE, but I don't know who knows what it was. But learning and evaluation were modified as well. So as you've heard in the earlier lecture, evaluation became more common. Learning became more common via video. Evaluation was modified, as I said, even at the national level for fellowship examinations, the evaluations were modified. But everything changed completely. Now, did knowledge increase? You heard that the students from Cape Town said that all they did was study for the 4 months, knowledge should be very strong because the students had no clinical duties, none at all. Now, if you're in 1st and 2nd year, you had no in classroom, and I suspect that most 1st year students, you can tell me where it works, although you don't know because you've been in COVID students right from the beginning. But I expect that the very 1st year, most people go to class, and in Toronto, they videotaped the classes, and you could watch online as well. But there was a certain presence in the classroom, but there's no presence in the classroom. So there's no presence in the hospitals either. So those clerks who were supposed to do clinical clerkship, they were not in the hospital. So what should they have been doing? They should have been independently studying. They should have read the textbook 5 times over. And in 3 months or 2 months or 6 weeks, you should be able to read a textbook. If you can't read a textbook in 6 weeks, you're reading slowly or you're playing on your computer. Okay. So knowledge should be very, very strong. Unfortunately, there's less motivation for excellence. I'm not standing around going, Grace, what are the 5 signs of appendicitis? You know what I mean? Or, something like that. Alex, what kind of murmur does this person have? So or go home and learn about murmurs. You have to do it all on your own. So there's less motivation for excellence if you're studying on your own. There's nobody to push you on a daily basis. You don't have to perform in front of your peers and in front of your supervisor and the patients. So was there a knowledge increase? There hasn't been. I don't know why, but I've not noticed that the clerks coming through now are any more knowledgeable than they have been. And in fact, as an educator, I lower my standard for evaluation, which is a sad thing to say. But there hasn't been an increase in knowledge based on the time taken off the clinical duties, which is a really bizarre thing. I don't know if it's the same around the world. Clinical skills, well, the labs have theoretically been available. I don't know if the clinical skills lab, we have a very strong clinical skills laboratory, surgical clinical skills laboratory in Toronto. And that's for things like suturing and laparoscopic stuff, et cetera, but there's no clinical skills lab for listening to a murmur or examining a person. This has to be independent study if your people are going to clinical skills lab, if they were actually open. I actually honestly don't know if the clinical skills lab were open or not. Again, there's less motivation for excellence. It is simulation, and simulation is great. Don't get me wrong, it's great, but there's nothing that takes the place of actually doing it in a person. As a resident or as a trainee or as a medical student, you can watch all you want. You can watch operations galore, but eventually you have to do it to learn. There were no hospital visits. There were no clinic visits. We were not allowed to bring students in with us. There are no patient visits at all. And so clinical skills, unfortunately, is very, very poor of those students, not just medical students, but residents coming through our program now that started during COVID. Because you must see to learn, and that's a problem. So on both prongs, the quality is not as good as it should be. Video conferencing, on the other hand, is very, very strong. You guys know how to do it in Zoom, Microsoft Teams, very, very strong, and it's the norm now. It will never disappear. I love that photograph that was shown about the 16th century or 17th century anatomy class. It was great. It's a huge advantage, however, as for transmissive group learning. And I think that the other two, we failed during COVID, and here we've profited from COVID. And it's a wonderful transmissive group learning, the tool that we use it, and people are now used to it. In that respect, it's very, very good. So what are we missing by not traveling in person? That was about medical education. What are we doing by missing about traveling in person? What has gone wrong? What have I missed by not traveling to the different places I've been invited to? People say, oh, it's perfectly fine here, Dr. Cusimano, come and visit us. And I can't, because my country won't let me visit, and B, I may be a little bit scared, but we miss what we can't see. We miss what we can't see, and that's what we're missing. I can give a lecture to you online and talk about this kind of stuff, but you can't really see it. And the assumptions that we have when we teach internationally are assumptions that are based on our local norm. Teaching, however, must be at their norm, not even just to start. You may go there and you want to bring them up to your norm. Like when I went to Ethiopia to start a cardiac surgical program, in the end, I want them to be able to not need me to go there anymore. That's what my goal is, to bring them to my norm. But at the beginning, you have to start in their norm. You have to see it to believe it. You cannot assume you know what it is. So here, they have modern cell phones. That's great. So you get off the airplane, people visit you, they've gone in their modern cell phones, they have modern cars, etc. The highways may be beautiful, but the hospital has a blackout. They may not have any water. They have no x-rays. They have no blood work. They have no materials to run their heart-lung machine. They don't have a sternal saw. So that's the stuff that you don't see unless you visit. You could be lecturing them about robotic surgery, but it's pointless to lecture about robotic surgery because that's your norm, not their norm. And that's what you miss by not going elsewhere. You have to go there to see what the local norms are to help your educational experiences. It's pointless to talk about this kind of stuff when they're dealing with no electricity. They have their local, they still have their ties. You know, no matter what you think, you have to see this in order to believe it. You have to see this in order to see that it's a different reality, no matter where you go in the world. Is it safe to travel again? Well, here's the new date. Here's the new cases. I've got 3 different places here. That was Ethiopia, where I was last. They're having nice big ones. Rwanda, where I have a friend in cardiac surgery. We want to get together with him. He's having their 4th wave. They've learned how to deal with COVID by getting more of it. China is a very safe place to travel, I expect. If you put all these slopes together, you see that the numbers are a little bit different. The numbers in Ethiopia aren't as bad as they are in Rwanda, et cetera, but China, again, is still a good place to visit. But when you put them all on the true scale, that's what it really is when you look at it. So there isn't that much COVID elsewhere, but you don't know whether the COVID is really there, and the countries are too poor. Remember what I showed, what it was like in Ethiopia. Some of it is pretty poor, and whether those people are really being measured in terms of COVID is hard to tell. The United States, is that a safe place to visit? It doesn't look like it here. India, I do some stuff in India, and when you put those margins together, India is perhaps a little bit dangerous, but they've only had 2 waves. Are they ready for another wave or 2? Who knows? I don't really know. So what have I done? Once you get the bug to travel, once you get the bug for international education, I'm sure Dr. Flegan will attest to this. It's hard to get rid of it. I've lectured in China and Brazil remotely since COVID started. They're sort of rounds type of learning. So you do teach there, sort of rounds kind of learning. I've continued to do the cardiac tumor conference. It's a web-based. It was web-based before the world shut down. It's for the whole world. You guys are all welcome to come. It's free to attend the conference in person or to go onto the website, look up Toronto Cardiac Tumor Conference, and you'll get all the archived lectures there, and you can learn whatever you want there. And I'm developing an international database in cardiac tumor called the International Cardiac Tumor Database there. And so that's what I've been doing. The International Registry to Assess Cardiac Tumors. We've gotten people from Canada, United States, South America, Europe, Africa, India, China, and Australia. We meet over Zooms, but they're very high-level meetings. It's a difference between this kind of meeting and this kind of education, the kind of education I've been involved with up until now. They're all experts in their field. I've gotten the biggest experts in the field in each one of those countries. And each lead then will engage in their own region to get individuals in their own regions. And we're going to give lectures to these regional programs. First, I'm going to give lectures to the regional areas, and I'm going to get them involved to educating their own people. And it's going to have worldwide interaction and cross education. So people are going to be educated by their own local area, in other words, continent needs. And we'll have international collaboration from all over the world to help patients with their problems. So this is something that you can do. This is a very, very high level thing. It's obviously way beyond medical student, but there's no reason why you can't engage medical students around the world to do this sort of thing that you've started today. I think it's all really good. COVID vaccine nations are starting. Will it make an end to it? It's hard to say. But what will happen after COVID? Travel in person will resume for sure. The telehealth and video conference will continue. Unified effort. We've had a worldwide, global unified effort to battle COVID-19. And hopefully this will allow collaboration where there was less before. You know, when you're getting countries that sort of didn't really talk to each other, all helping each other during COVID, hopefully when COVID goes away, whether it does or not, it's hard to say, but people will be interested just to be able to get the numbers from around the world with the COVID, whether you believe them or not. That shows some collaboration in the world where none existed before. You know, we see information coming out of Russia and China and things like that. Education international will be more important than ever before, and there still will be challenges, both from geopolitical as well as financial. You still will be going to a place where they need basic things like connectors for tubing and things like that. So that's it for my talk. Does anybody have any questions? I'd be happy to answer them. I don't know what time it is, whether we're too late.
It's noon, so we could probably take a couple questions. Because I know we started this presentation a little bit later. Unless Grace, you have anything.
Yeah, sorry. I just wanted to jump in and say, yeah, we can go probably until like 12:10. And also we have like a lunch kind of break, but if people want to stay in the breakout rooms and continue talking, that's totally fine. If you're okay with that, Dr. Cusimano.
Yeah, fine.
Sure. So we'll do some questions till 12:10. So if people are welcome to put them in the chat, I can read them out for you, Dr. Cusimano.
Sure.
Oh, as well, yes. You can, you raise your hand, Dr. Fagan. You're welcome to ask that.
Hi, Dr. Cusimano. Thank you very much. That was very interesting. So I was wondering, at the University of Toronto, have you got any structured, I'm sorry, I got called out briefly during your talk, so you might have covered this. Have you got structured kind of external rotations to other countries in any of the surgical specialties?
We have an office of global surgery at the university. I don't think we have any structured ones. There are a number of students in our university that have gone out. When I was a program director for cardiac surgery, they asked if they could do a rotation there, and I okayed it. I think it's wonderful. We do have an office of global surgery, but I don't think we have any structured rotations in other parts of the world that are part of the program.
Yeah, yeah. And just a follow-up question. I was quite struck by your comment about the residents and senior residents as well, just for a prolonged period being completely, and this wasn't, they weren't being redeployed to the COVID clinical service. They were just completely out the hospital.
That's right. No residents at all. They were told they weren't able to come in.
I mean,
Nothing.
that's bizarre. Because I mean, our biggest problem was that we had to kind of shore up the medical staff looking after COVID patients. So we had to redeploy registrars from all the different surgical disciplines to the COVID clinical service. And that obviously had an impact on people's clinical training, but they were in the hospital and they were seeing COVID patients. So I'm really amazed that the residents weren't.
Eventually, they came back and they were redeployed to some areas, but we mostly redeployed nurses and clinical, physician's assistant type of people.
Yeah.
The residents, for the first part, as I said, I don't understand why the university did that, whether it was some sort of insurance sort of thing, in case somebody got COVID or not. But our senior residents, we had one woman, she's a very good resident. She's finished her residency now, but she was so looking forward, and we were so looking forward to letting her do more and more and more and more, and they took her away from us. It wasn't optimal.
Was that the case across Canada?
I don't
in all
know.
the programs?
I don't know. I honestly don't know. I think it was the case in all programs.
Hmm.
For the medical students, absolutely. But for the residents, I suspect it was all the programs, because the residents are not program based; they're university based.
Yeah. And maybe I don't know if there are any other questions, but if there aren't, I mean, something we really struggle with here is, and you alluded to this earlier in the discussion we had after my talk, was the small number of adult cardiac cases, even under the best of circumstances. Does that remain an issue in Canadian training? I mean, certainly an issue for us.
Yeah, one of the big issues, interestingly, for a cardiac surgeon to get a patient, they need an angiogram, and so we need to have their anatomy defined. And we found here that a lot of patients did not want to come to Toronto. They didn't want to come to a big hospital. The cardiac surgery here is isolated to a few centers throughout the province. They're all university centers, and the patients didn't want to come because they hear in the news Toronto has 700 people this week or this day, 800 people. They're scared silly to travel, and some of these people were really quite sick. I saw a lot of people died because they were scared to come to the hospital. And now that COVID's essentially finished, it's not really finished, but essentially finished, like, people are less scared to travel. There is still some fear to travel, but we're not getting the people having the angiograms. People are not going to the hospital with their cardiac conditions. So subsequently, cardiac surgery is really, really slow. Other places like hips and knees and things like that have a huge backlog. Cardiac surgery has no waiting list whatsoever. Nothing. Zero. Because patients are not coming to the hospital with their cardiac problems.
Yeah.
So it hasn't filtered back to the system. It's really, really quite interesting how people will suffer and die for that kind of stuff.
So that's fascinating. I mentioned earlier this meeting we had yesterday with all the clinical heads and our chair of cardiac surgery, Tim Pennell. There'd been talk about normalizing COVID and trying to find a way to manage to keep services running as much as normal, and should we have any further waves of COVID. And Tim's comment was that, in fact, what we've normalized is people dying at home from pathologies that have gone untreated. So that, I mean,
that's right.
What we're saying. That, and it'd be interesting to figure out to what extent that's, perhaps that's been more of an issue in some surgical disciplines than others.
We found a number of people, they call us, they've been at home for 12 hours and they come in cardiogenic shock and really nothing to do. Or dissection patients come in and they rest on you right then and there because they've waited hours and hours at home. Everybody's really scared. Interestingly, I was talking to a fellow yesterday. We had some headshots done in our hospital yesterday, and I was talking to the photographer, and he's got a couple of children. I think it's 7 and 8 or something like that. And, there's a huge fear amongst the children about death from COVID and going places, going outside. Because if you think about it, a 5-year-old has known nothing but COVID for their whole life. Mm-hmm. Their conscious memory is nothing but COVID. And he was telling me how his son, who's going to turn 8, I think it was maybe 7, 8 or 9, did not want to go to hotel with a pool and bring some of his friends because he was too scared of COVID. It's a big problem.
Yeah. Dr. Cusimano, I see there is a question from Dustin Tanaka,
Go ahead.
and reads, what is something that you've learned from the surgeons in places you've taught, you brought back to your practice in Canada?
There's many ways to skin a cat. You know, the people who are supposedly the most innovative surgeons that I've known have been the ones who've traveled the most. So you learn little tricks from them. But the biggest thing is there's different ways to skin a cat. Just by showing you those pictures of those people putting the gowns on and things like that without gloves on. Not everything we learn is dogma, even though we teach it as dogma. Those are some of the biggest things. And to do operations with less than you expect to have, those are the biggest things I've learned. Yeah. Also, how people deal with each other and their patients and stuff like that. That's another thing that you can always learn.
Right. Thank you. We have Hartle also has a hand up right now.
Go ahead.
Hi, Dr. Cusimano. Thank you for the talk today. So what I understood is you're really passionate about tumors in cardiac surgery. And I was wondering how you got involved in this area because it's a very niche area. So I was wondering if you had like formal training or you went on and exploring on your own.
No, I went exploring on my own. I've always had an education bent. And so that's when I found out that there are other people that wanted to learn, I did it. So it's all self-taught. I've been doing this since 2006. Our university global office, I think, is only about 5 years old. So I've been doing it for a long, long time on my own. It was just something that I was doing, you know, a long time ago. I sort of went on my holiday, take 2 weeks off and go traveling somewhere. Now, and you'd sort of, do you really need to go there? You know, we need you here. We need you to operate and all that kind of stuff. And I would just say, okay, that's fine. I'm going to take a holiday. But instead of taking a holiday, I would take a holiday in another country. And you just go there. And sometimes it's to teach them how to do a new technique. Sometimes it's to help validate what they have. Sometimes it's to help them with an operation that we do in Toronto that they don't do elsewhere, say the United States or something like that. But it's sort of self-taught. It's more formalized now, but when I started, it wasn't anything like that.
Okay, thank you.
And then I believe the last question we have currently in the list here is Uzair.
Yes, hi, Dr. Cusimano. Thank you for the presentation. I'm a second year MD student at UofT, and so I have a bit of experience with what you're talking about in Toronto. And you alluded a little bit to trying to establish formal education programs, for example, the one in Ethiopia. And having grown up in Pakistan, that is sort of what I'm interested quite a bit in as well. My question is, what do you think are some challenges as an outsider to go into a country and develop a program that certainly would be one of the strongest ways to develop long-term surgical capacity in that region? But as an outsider, you might have faced some challenges. I'm just wondering what are your thoughts on that?
I think the biggest challenge you're going to have, and I think it's great that you're doing that. The biggest challenge you're going to have is the local realities, and not just local realities from a financial point of view, but from a political point of view as well. You may not understand what it's like to do that, and what you need to do from a local reality. I showed you the local realities, some of the concepts of the local realities, but you need to overcome those local realities. That's going to be a big problem. Why don't you just use this type of suture? And when you're talking about this type of suture works better, and you realize that they have a needle that they have to put a piece of silk through, that gives you an idea about a simple example of what you're talking about. When you're talking about, let's do an operation today, and they don't have enough drugs to put a person to sleep, or they don't have enough reagent to do an arterial blood gas. Those are things that, why are they asking me to come to the country when they can't even do an x-ray? Those are the kind of things that you're going to build up again. It doesn't mean you shouldn't do it. But now with this international cardiac tumor database, the Interact database I'm doing, I'm trying to go at it from another end. They've asked me, in other words, from the up down, from the high end, the highest level people in the country that I can visit, and hopefully they're going to have influence. It's easier to go to the ministry, to the government, if you're this high than if you're this high. You know what I mean? So that's where I'm starting to go now. They've asked me to give some lectures in China and to another province. This is a bunch of video conferencing, and I've said that's great. Next time we do this, I want to lecture across the whole country, because I've had some influence locally. I've got them when they built a new hospital, put a clinical skills lab in there, and I've had, as I said, some competitions in different residents. So the residents get to meet each other around the province and around the area. But we want to do that at the national level. And you're not going to be able to do that at the national level, but you yourself, who's interested to bring healthcare to a higher level to Pakistan, may be able to do that. But you have to realize that the local realities are local realities that you may not have any influence or may not even realize are there until you actually go there and see what the local realities are. So it's going to take a while. It's a great opportunity, and it's a life. You're in second year medical student, but you'll spend your whole career doing that. And it will be very, very rewarding for you to do that. And it's something you start and don't stop. You need to have the start. If you don't start, you're not going to do it. But those are the realities, I think. So I'm at the level, higher levels now in the countries I'm going to, but hopefully it's going to filter upwards and then downwards. And I want to do multiple spheres as well. I want to make sure education is standardized throughout some of these countries where they're not as standardized. And I want to make sure that care is standardized, or even just with the International Tumor Database, I'm just trying to do identification of cardiac tumors around the world. Because I've been called from Pakistan about somebody who had a cardiac tumor, and they get on the web and they find out I have a cardiac tumor course, and they ask me about their family member, and I don't know where to send them from Pakistan. So that's what I'm trying to do with this international. So that's just a basic international education, medical thing that I'm trying to do. So there's multiple areas that I'm trying to get to now, but that's at a very different level than you as a medical student. Doesn't mean you can't do it. Doesn't mean you shouldn't do it. In fact, you should do it. And if there's anything I can do to help you or anybody else here, I'm happy to help them. You can give my name out to people. They have it at the front.
Yeah, may I ask a follow-up if that's okay? I know we're okay. I don't think there's any other questions. Sorry, go ahead.
Yeah, you can go for a quick one.
Okay, I'm just wondering, Dr. Cusimano, that what specifically is the role of like a formal residency or fellowship program? So I know you do a lot of teaching, like one-off teachings or lectures, or you go regularly and teach in the OR. But I wonder what's the role of specific structured programs versus just informal regular teaching?
Yeah, informal regular teaching is a one-on-one thing. We have to, and I have to get beyond that. That's why whenever I go to a place, if you do one-on-one teaching, you don't give a lecture, you might as well not even have gone there. Mm-hmm. It has to be more formal, more structured, and at a higher level.
I see. Okay.
That's what you have to do. If you're interested, and you should call them now, is the Office of International Surgery.
Yeah, you're interested. I'm working with Dr. Errett on a master's project on this.
Yeah, and that's what you have to do. He's a great guy.
Okay, great. So that does wrap up the list of questions we have. I just want to take a quick second to thank Dr. Cusimano once again for taking so much time out of this Saturday to come chat with us here about global surgery.